Uh, let's go to the next speaker, Kavita. Please come forward to talk about infectious scleral abscess management. Again, your time is 10 minutes. So
A very good afternoon. At the outset, thank you APAO, AIOS and my own VOS for giving me this opportunity to present infectious scleral abscess management. We all know characteristics of sclera being a very tough and because of the composite nature it has, and also covered with episclera and sclera, along with low metabolic activity, avascular structure and impermeable to infection. But if it happens, then it is disasters. We have all studied types of scleritis, be it anterior when we classify again into diffuse or nodular, a posterior scleritis variant, necrotizing, non-necrotizing, and today we will be dealing a little bit on immune-mediated and infectious, which will again be divided in endogenous and exogenous variety. Now, immune-mediated, whenever we think of, take a proper history, which is going to be very important in the diagnosis of immune-mediated. Usually, it have a bilateral presentation, and when we see on a examination, we can see a little bit thinning of the sclera and a bluish hue, which can be seen. There are usually signs of remission when the disease is been at the remission stage, and it usually responds to the corticosteroid treatment. When we talk about infectious scleral abscess, it is less compared to the immune mediated, and it has been reported almost about 15% of cases. They are divided into endogenous and exogenous. Endo means whenever there is an infection, systemic infection in the body, be it a syphilis or tuberculosis, the presentation could be infectious, systemic infectious. And when exogenous means whenever you are having any trauma because of which the scleral abscess has been there, or extensions from the ocular structures, be it adnexa, be it a cornea or a retinal structure. And post-trauma, post-surgical, where it could be because of any of the surgeries like cataract, pterygium or adnexa. When we also differentiate between them, when we examine it on examination, you have to note the purulent exudates in infectious, and it is not so into the immune mediated. And during investigation, make sure that in immune mediated you do note RA factor, ANA factor, P ANCA and others, which they are not present or positive into the infectious variety. This is an example of nodular scleritis. It was because of the viral etiology and which was being treated by steroids and antivirals. This is a flow chart which I have downloaded from a study where it has nicely represented the immune and the infectious etiology. Immune we have already discussed. Now infectious etiology, when you see that when you have taken the sample, send it for the culture and sensitivity. If you get something, then it's good. If you have not got, you can repeat the same thing again. Do send it again for the culture and sensitivity. Even after, if you are getting nothing, again go back, have an ocular examination, look for any scars or anything which will give a clue for probably an viral etiology. If not, the patient is giving an history of trauma or something, go for antifungal presentations. If not these all, then you can still start them on steroid therapy, masking the immune pathology. Also, a note on posterior scleritis. We all know that it has not been seen from front, but yes, B-scan usually helps us to come to a diagnosis of posterior scleritis and fundus examination. Now, should we intervene, and when to intervene? Yes, it is very necessary that whenever you are having multiple abscesses, if you see, it's better to go ahead and do a surgery debridement. There has been multiple studies which show that you should go ahead and do a thorough scleral patch graft or an surgical intervention to prevent the globe. Now, why should we intervene? It has been said, and we all know that scleral abscess is a destructive, suppurative nature and has very poor antibiotic penetration. And it can lead to devastating complications like end-off and pan-off, and we can lose the globe. Now, these are the few examples where it was a large corneoscleral melt which we can see with an iris seen through. Now here the surgeon has taken a nice large corneoscleral graft, and we can see that after healing the patient's globe has been properly intact, and we can further do any other surgeries to have a better vision. In a similar case of scleral secondary to the retinal surgery, the infected scleral buckle, here also they have removed this agent, the scleral buckle, plated it on the blood agar, looked for the organism, and here when the bed is not so good, they have again applied a scleral patch graft along with the antibiotics. Whenever you see an offending agent, be it any devices, it is better to remove it off and to save the globe. As I said, there are many theories which do say that you have to intervene early in cases of a large scleral abscess. So you can use a cryo or a lamellar or a PK, as we have already seen, for the better outcome of the patients. If we don't, then it could lead into a enucleation or evisceration. So early and repetitive surgical debridement is heavily advocated in scleral abscess patients. A note on masculine scleritis. It has been very rare, but yes, we should also have that in point, that when these things are not working, are we looking for something else? So there are very few cases, 2 or 3 reported as in masculine scleritis. So my take home message will be, if it is not responding, do an early intervention to have a better outcome. Thank you.
Yeah, there is a question from the audience. You can, yeah. Expert panel, Dr. Subodh, yes.
Madam, I would like to ask, when do you start antimetabolites like tacrolimus or cyclosporine in a non-infectious scleritis?
Sir, I think
Yes.
whenever you see that the patient is having higher disease in case of immune mediated, it is better to start along with the corticosteroids and the topical steroids.
No, like clinically seeing, like if you're used NSAIDs, also the corticosteroids,
Take a chair
then
and-
how long you wait for the disease to proceed and then you start with the tacrolimus or the cyclosporine? Like
Sir,
what do you see on clinical things?
Oral we are talking about?
No, topical.
So topical you can start. Tacrolimus topical we can start.
Okay, thank you. And what about biologics nowadays? They are saying many things about
Yeah.
biologics.
In case of topical, sir?
Yes, sir.
So you can, there are not many theories about the biological indicators and all, but yes, tacrolimus or along with the steroids, yeah, you can go ahead
Okay.
at the first instance.
Thank you.
So any autoimmune now biologics are going to be there. So we have to be ready.
As
Humira.
we
or-
take the corneal, scraping, the similar manner do you take the scleral scraping?
Yes, ma'am. And whenever you see any offending agent, it is better to remove that and plate it on agar. And if you see that the bed is not good, it is better to put a patch graft of anything so that you can save the globe.
Okay. That case you had shown, the corneal graft only was put on cornea and sclera,
Yes,
isn't
yes,
it?
ma'am. It is a large corneal sclera.
Okay, yeah. Good presentation.